welcome and greetings. Welcome to the 162nd session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Chandra Mickles. Dr. Mickles has received her optometry degree from the Sunny State College of Optometry and also her MS degree from the UAB School of Optometry. She also completed a cornea and contact lens residency at the UAB School and a postdoctoral research fellowship at the Birmingham. She is a fellow of the American Academy of Optometry and also a fellow of the Scleral Lens Education Society. She is one of the eye care leaders who has built her dedicated professional in terms of being into education, patient's care, and also research. Previously, she was into academics, but currently, Dr. Mickles is the North America Professional Education Lead for the myopia section at Johnson & Johnson's Vision. Whatever she's going to talk today, it's all her experience in the clinic when she sees patients and does not really reflect or promote Johnson & Johnson's Vision where she is associated with. Today, she's going to talk to us about the guide to myopia management, and she'll take us through some case studies and also some examples on how can we incorporate and what should we be doing if we see a myopic patient and manage them. So welcome onto our platform, and let me just leave the screen time to you.
Thanks so much for that warm introduction. It is such an honor to be asked to give a presentation. And it's wonderful to see that so many students have joined for this. I'm very passionate about educating the future leaders in eye care. I've done that for many, many years, and it was such a great pleasure for me. Here are my disclosures. As he shared, I currently just very recently joined Johnson & Johnson Vision as the North America lead for professional education on myopia portfolio of products. However, today I will not be speaking on behalf of Johnson & Johnson Vision. What I'll be sharing is my own opinion. So only a few months ago, I was in the trenches seeing patients, and 5 years ago, this 5-year-old that looked just like this little guy presented to me. And at only 5, he had nearly 6 diopters of myopia and had not just one parent, but 2 parents that had and an older brother that had high myopia. So for me, 5 years ago, we did not have no way near the options of treatment options that we have today. So the question of myopia control or not actually was a question, where today it would be no question that we would initiate myopia management for this child. But what can be challenging today in making the decision is which option that we would choose for a patient like this one. So we're going to pull up a poll, and I want you guys to take a look and decide based on that patient. Remember, he was a 5-year-old. He had almost 6 diopters of myopia, and his both parents had myopia. And you see that he was also esophoric at near. So which option would you choose?
So majority, almost half of them are saying atropine, and then followed by the majority in orthokeratology, and a couple of them also would prefer soft multifocal.
Yeah, very interesting. So yes, majority atropine and followed right behind by ortho K. Okay. And I think, as I mentioned, yes, this is a challenging decision, whichever option that you chose. And as we saw, it's a very big split. And the reason why it's challenging is because what we know about myopia management is changing at a rapid pace. Before you joined, we were just discussing, like only a few years ago, we really didn't teach much of this in the classroom, but now because of all the advancements, we have to incorporate almost everything. So what we've seen is changing at the rapid pace, which is making it tough for us to stay up to date. Yes, and kind of making the decision on when to initiate, when to stop, which option is almost like trying to drive to a new location without GPS navigation. And I'm probably dating myself, but I remember a time when we didn't have GPS, and I'm thinking now I would panic without some GPS navigation while traveling to new locations. So today I'm going to be your GPS guide to myopia management and give you some guidance on selecting the right candidates, on the myopia management options, what is considered success, and give you some tips to have success so that you'll be armed with the latest evidence-based strategies and recommendations to have successful outcomes with your future patients, for those students, and then those of you for your current patients. So that if a little guy like this one is in your chair, the question will not be myopia control or not. You will be confident enough not to have the need to refer him out. So why should you care? I think many of you guys know this, that myopia is reaching epidemic levels around the globe. Yes, today we have 2.5 billion people with myopia, but it's expected to almost double in the year 2050 to 5 billion. But some might say, well, isn't that what we do? Don't we want my myopic patients because we correct them with glasses and contact lenses? Well, let me share with you my story. So a few months ago, only 2 days before starting my new job at Johnson & Johnson Vision, which was the same day as my last day at Nova Southeastern University, I saw a flash of light. Yes, while rushing to see my last patients and close everything out at Nova, this 12 diopter myope saw a flash of light. I said, no way, this cannot be happening to me. No way can an RD be happening. And then a few moments later, I saw a series of floaters, followed by more flashes and floaters after that. So that was one of my nerve-wracking myopia experiences. And as such, I know the impact that this disease can have on life, right? On quality of life. Even some simply can't even find my glasses in the bed so I can see the alarm clock or make it to the restroom, or even being on the road, panicking, hoping I can get home because my contact lens popped out of my eye. So yes, people with high myopia experience a similar quality of life of patients with keratoconus. But this is not only a concern for people that have high myopia or simply a nuisance for people with the low myopia. No, myopia is a disease that can lead to serious complications even for the young. Yes, each diopter of myopia matters because every diopter increase in myopia increases the risk of MMD by 67% and RD by 30%. So the why here is that it is so important to start early because this disease can lead to serious complications even for those who don't have very high myopia like myself. The other reason of why you should care is because it's important for us to do our best as eye care professionals in maintaining sight and quality of life, but it also can set you apart in your future practices. And it is becoming the standard of care. Some of you might know that the World Council of Optometry recently passed a resolution calling for the standard of care for myopia management. And I live in the States, and many of our associations are on board for this as well. So how do we prevent this 2.5 billion from becoming 5 billion? Well, I think the key is to understanding what I said I was going to share with you in this presentation. Is really knowing when to start the management options and the keys to success. So let's talk about the candidates. And I want you to take a moment and think to yourself, for all these children are 6 years old, would you initiate treatment for the 4 diopter myope that has no parents with myopia, or the patient has a 1/4 diopter myopia but has 2 parents with myopia? And I think for the most part, the way that many of us were looking at it, not too long ago, is we kind of looked at all the risk factors and said, okay, this patient has these risk factors, and as such, I'm going to initiate myopia management. And we think about parental myopia, we all know that that is a key risk factor, and as such, with one parent, there's 2 times greater risk. And with both parents have myopia, there's up to 6 times greater risk. But what we know today, it may not be that part of that parental myopia related to genetics, as only 5 to 35% of the variation of refractive error is explained by hereditability. So yes, we have all these risk factors, but I think what's important is to really look at what is the strongest risk factor for myopia development or progression. And if we think about my patient here, and this is where I want you guys to put in the chat your thoughts, is the biggest risk for him becoming more myopic, is it his age of onset of myopia, right? I mean, obviously he developed myopia very young. Is it his ethnic background? Or is it that his parents have myopia or high myopia? So again, what is the strongest? What do you think is most concerning or the strongest for him becoming more myopic? Is it his age of onset of myopia, his ethnic background, or his parents having high myopia? So I would love for you guys to put your thoughts in the chat. Yeah, genetics, parents, family background, parents having myopia. So parents, again, I just think heredity due to influence of the parents, and just age, hereditary, high myopia parents. So parents' age. So it's a mix between mostly parents. We see some age. All right. So let me share with you what the latest research has shown here. All right, based on the latest research, age of onset of myopia emerges as the strongest predictor of high myopia as the child gets older, so even greater than the parents. So the reason why I share this is because the point here is that when you see a child who has myopia, it's important for us to go ahead and initiate treatment, especially if they're young, like my patient. Carla Zagnick and others even did a great job in identifying by age children that are high risk of becoming myopic by the 8th grade. So you see even a 6-year-old being hyperopic, they're at great risk of becoming myopic. So definitely my patient, I'm just gonna call him Sammy because that's my dad's name, so I'm gonna keep calling him this patient. But yes, even obviously for him, we definitely want to initiate. And I think also the key here is we want to monitor as early as possible. In the States, there's a push to have children have annual eye exams starting at 6 years old. And a part of it is that reason here, is that we can pick up on if they have too much myopia or less myopia, and that is expected for their age, so we can initiate myopia treatment early as possible so that we can prevent those outcomes that I shared with you regarding me as a high myope. So early is better as regarding the monitoring. And I think of it this way. If I had a 60-year-old African-American male with an IOP of 29, visual field defects, and a family history of glaucoma, I wouldn't wait to monitor him. I would go ahead and monitor him closely. He doesn't need frank glaucoma for me to go ahead and monitor him closely. And similarly with our children, we don't need to see that they have high myopia before we start initiating myopia management or even monitoring. Like if I start seeing someone that has, lower hyperopia than expected, at least I would start monitoring or even recommending some lifestyle changes. But as you see here, if we look at these children and all of them are 6, I think all of them would be candidates for myopia management. But again, monitoring early, and even if they don't have myopia, it doesn't hurt to start doing some lifestyle recommendations. As we know, limited time outdoors is a risk for myopia development. And as such, we definitely want to get the children outdoors at least 2 hours a day. It also doesn't hurt for them to not spend so much time doing mirrored work. It's been shown that reading at very close distances for continuous periods of time can lead to increases in myopia. But what is interesting, there's very limited evidence linking increased screen time to myopia. And most of that, I believe, is related to the way the studies were done. It's really difficult to do a well-controlled randomized study where we eliminate some of these confounding factors of myopia progression in doing these studies. But I also get the question from parents is, has there been an impact of COVID-19 in myopia? You know, is there such thing as quarantine myopia? And there have been some great studies done in China that have shown that during the quarantine time, there were significant increases in the prevalence of myopia. So yes, we do not have clear evidence, but something is going on. And again, as I said, it doesn't hurt to recommend to parents to limit their child's time on digital devices. So here's a summary of the factors that are associated with myopia. And as you guys were correct, as far as parental myopia is important and it is strong. Education is also important. Time outdoors, screen time, as I said, we're still not sure about that. And then the ethnic background, which was interesting to me. It's not the ethnic background itself, but more the cultural attitudes of that particular group. That is what it seemed to appear, that particular group might be more involved in education or strongly believe in education, which is more of a strong causal relationship with myopia. And again, as what I mentioned, a strong predictor is the age of myopia onset. So now we know the strong factors. Clearly, my patient is a good candidate for myopia management. But if we look at his background, which option is best for him? And because of my background is that I was heavily involved in contact lens fitting and research, we're going to focus today a lot on the contact lens options. So how do contact lenses slow the progression of myopia? Well, the theory is that with peripheral hyperopic defocus, it accelerates axial growth. So with spectacles, right, the image is focused on the retina centrally, but in the periphery, it is behind the retina. And as such, there's this hyperopic defocus that stimulates the eye to grow. With peripheral myopic defocus, the image is in front of the retina and as such does not stimulate the eye to grow. So with ortho-K lenses, as we're changing the shape of the cornea and causing the epithelial cells to move out into the periphery here, this causes this myopic defocus and as such doesn't stimulate axial elongation. Similarly, with soft multifocal lenses, there's this relative plus here that causes this myopic defocus and as such as well doesn't stimulate the eye to grow. So is it the best option, ortho-K or soft multifocals based on my patient? So again, he has almost 6 diopters of myopia, diopter still. He has an ESO posture near. He denies allergies. He's not an athlete. And you see there, that is his pupil size. So let's talk about what is considered a good candidate for ortho-K. And I mean ortho-K for myopia control, which is a little different than the candidate for ortho-K for its traditional use of temporary reduction of myopia. And ideal candidates are those who have patients that have large pupils, and I'll get to that in a second. Athletes, as many of you probably know, and then children who are unable to wear soft contact lenses due to allergies. And I'm going to this because it's a question I get often where, you know, ECPs and students aren't sure, you know, which option that they should go with. So let's talk about the pupil size. So here we're going to imagine that this is the ortho-K lens, and here is the treatment zone, and then here is the area of peripheral myopic defocus. So if we have a large pupil, right, the peripheral myopic defocus will lie in the pupil, and therefore that patient will get the peripheral myopic defocus, which is what's slowing the progression of myopia. However, If we have a small pupil, now that area of peripheral myopic defocus is outside of the pupil, and therefore that patient is not getting that peripheral myopic defocus. That is what is slowing the progression of myopia. So if you look at this patient here, you see here, this is the area of peripheral myopic defocus. Is not going through the pupil at all. And as such, you wouldn't get as an effective outcome if this patient had a larger pupil. So if we think about the average treatment zone size for OK, it's around 3.5 millimeters, 4 millimeters. And then that outside zone of peripheral myopic defocus is 1.5 to 2 millimeters. Ideally, you'll want a pupil size to be around 5 millimeters. Again, this above pupil is too small. So that's why when you're selecting your candidates for ortho for myopia control, not for the traditional means, you want to look at that pupil size and maybe being 5 millimeters or bigger. With children, the issue with large pupils in general, most people know that can cause some halos and decreasing, contrast sensitivity, but most times children can adapt to that. And in my experience, the children that I've treated haven't had issues with this, okay? Now, looking at it in another way, and there's been a lot of discussions on this as far as the optic zone size. So optic zone size may matter as far as, the efficacy of the myopia control, meaning if I have a smaller optic zone size, there is a smaller treatment zone, and then more of this peripheral myopic defocus will get through the visual axis, and therefore will have a better treatment. There was a study that did take a look at this. The smaller optic zone size, with the 5 millimeter optic zone size, there was a greater reduction in axial elongation there. For both sizes, there was the same contrast. There was same reduction in same visual performance. However, with that smaller size or optic zone size, there was a decrease in contrast sensitivity. So I think that is to be expected. However, keep in mind, as I said before, the children more adapt to that than an adult who's like driving and things like that. So I think more studies are needed. However, it appears that 5 millimeter optic zone may be advantageous. The other thing you want to look at is, of course, if a child is an athlete, I think Ortho-K is a great option. The greatest benefit of Ortho-K lenses is the freedom from glasses, the freedom from contact lenses during the day. And so with athletes, especially swimmers, we're not worried about the risk of wearing contact lenses while they're swimming and the complications associated with that. And just in general, for any athlete, not worrying about wearing contact lenses or spectacles while doing a sport. But let's talk about refractive error. We are so fortunate today to have Ortho-K options that can treat pretty high refractive errors. However, greater than 4 diopters, it has been shown that increases the risk of central staining. Higher levels correction greater than 4 can also increase the risk of a decentered lens and a treatment zone. So based on the International Myopia Institute guidelines, especially for children, the ideal candidates as far as refractive error are up to a -4 diopters. You can do more, but I'm just giving the recommendations that are ideal. And it's great that we have many, many options today for our children going through Ortho-K as an option for them. So for Sammy, is Ortho-K the best option? So we look at his refractive error is definitely higher than that 4. So maybe not. He's not an athlete, so it's not a big advantage for him to use Ortho-K. Doesn't have allergies, he doesn't have a significantly large pupil, and as far as his ESO posture, the Ortho-K is not really going to help with that. So for him, I decided not to proceed with Ortho-K. But let's see if soft multifocals are a good option for him. So soft multifocals, you want to make sure that the child is responsible enough to wear lenses during the day. And let me tell you, Sammy was very, very mature for his age. He was already asking me at 5 years old how to clean contact lenses, which was very surprising to me. And there's a huge, large parameter range. For the most part, we could do better with the silver soft lenses. But as far as the sphere, it goes pretty high for the soft contact lenses. So is he a good candidate for soft multifocals, which many did not choose, but I think in what was explained to me in the area where most of you guys are coming from, is not used as often. But if we look at him, he's very mature for his age, as I said. If we look at his refractive error, there are definitely soft multifocals that come in his prescription. He's not an athlete, doesn't have allergies, and with the ESO posture, that multifocal should help him out with that. So I ended up choosing a soft multifocal lens for him, and this image or video of him was when his pupil was somewhat dilated. I took the video while he was getting dilated, so I could get it done. What I ended up doing at the time, 5 years ago, believe it or not, I don't know, in the States, we did not have a daily disposable multifocal lens option. So I had to go with a reusable lens, and center distance is currently the most effective option. And at that time, so I went with a center distance multifocal lens. Now, here's a poll question for you. Which ad would you choose for him? For myopia control.
Majority of them are in the low ad category, if I may put it that way, 150. And then some of them say about 2 and 250 as well.
I see. Okay. So let me share with you the results, the recommendation based on the latest research. So actually in the 21% of you that you got this exactly right, is actually the 250 ad. And here is the why. The current recommendation is to prescribe the strongest ad available without causing suboptimal vision. So the strongest ad that the patient can tolerate subjectively and objectively. So the either starting point, maybe I should have phrased it that way, the ideal starting point for him would be a plus 250 ad, okay? And the latest research in the Blink study, they definitely demonstrated that with Jeff Walleen, showing that the highest ad was most effective, and the high ad was the only power found to cause a meaningful slowing of eye growth. So you want to start with the highest ad and see if they can tolerate that. So here's another poll here that we're going to pull up after I go through what happened here with my patient. So I picked a reusable lens for him, and here is the power, minus 550, a plus 250 ad. But he did have some blur in the distance. So what would be the next step? Should I reduce the ad for him, or should I add more minus to that spear power? So what do you think? He's getting a little blur in the distance. Should I reduce the ad, or should I add more minus to the distance power? Just only about a half diopter more minus.
About 60% said that they would reduce the ad, whereas the others said that they would add more minus and keep the ad the same.
All right. So here are the results here. The recommendation, not the results. So the recommendation is to add more minus to the spear, okay? And no more than half of diopter to the distance power, because you want to keep that peripheral myopic defocus as much as you can. So you want to try your best to keep that same ad if you can. So remember, it is the ad here, right? The ad is what's causing that peripheral myopic defocus. So you want to keep the ad. And again, those studies that looked at incorporating the high ad is where they found a meaningful effect. So when we start taking away that ad, we're not getting that same really much of an efficacy there, okay? But no more than a half a diopter is what is recommended as far as the distance. So as time went on, we were fortunate to have some daily disposable multifocals that came on the market. As you know, now we have MySight, which is approved. We have in certain countries, we also have Ability One Day from Johnson & Johnson. We also have NatraView, which is not improved in the States for myopia control, but a lot of us use that daily lens. So I chose one of those lenses and used it with my patient, Sammy. And what were the outcomes? So now he is 10 years old, and he has excellent vision, good binocular vision, and no significant myopia progression during this time at all. So great outcomes with the soft multifocal lens. So which is the most effective? And I'm just going to go through this option just in lieu of time instead of doing a poll here. And so we know that 1% atropine is the most effective. However, there are side effects such as blurred vision and photosensitivity if we use the 1% atropine. But I think most are surprised when you look at the Ortho-K versus the soft multifocal. It's actually similar efficacy. And I'll go through the why here. We also have low concentration atropine, and it's around 30–40% as far as its efficacy. And then we have the spectacles. So as I mentioned, in the States, we do not have FDA approval for the spectacles yet. So that's the only reason why I put it at 3. I've definitely seen some studies with great results and around the 60% reduction. However, only time will tell. And if I was in person, I would love to hear your thoughts, as I know some of you probably had an opportunity to use the new Hoya lens and see the compliance and how the children are seeing with that lens. But I said, for now, time will tell where the spectacles stand. But if we look at the Ortho-K versus the soft multifocals as far as efficacy, and I said they have similar efficacy, let's take a look at this child. So we say we have this child here, and he's 7 years old. If we don't do anything, right, by 17, he'll be a -9. If we initiate Ortho-K, then he'll be a 7.5 diopter myope. If we introduce multifocals, he will be -7 and almost basically the same. So if you see here, the difference here is not clinically meaningful. There is this new modeling of the cumulative maximum treatment effect, which I'll go over a little later in this presentation. But over 7 years, similar results in that the options are clinically equivalent. So when we look at making our decisions regarding Ortho-K and soft multifocal, it's not really looking at the efficacy, it's more looking at the patient's lifestyle and making that decision and looking at their refractive error and other things about that patient as far as pupil size, etc. Now, should we be using percent treatment effect? As you saw, I was using percent treatment effect, and we are going away from that because the percent treatment effect is misleading because it can vary over time, and the treatment effect, as we know now, it varies based on the patient's age. Also, the relative treatment effect slows over time. Mostly, a lot of it's happening in the first year. So when we do the percent treatment effect, it can lead to false expectations on the long-term effect. Efficacy, most of us feel now, should be described in absolute terms, like absolute reduction in axial length and absolute reduction in diopters, not looking at it as far as relative percentages. We talk about atropine. As we know, the low concentration atropine does work well and doesn't cause significant side effects, and it is an option that I have used as well. Based on the LAMP study, the 0.05% appears to be the most effective. Okay. Now, which is the safest when we go back to the contact lenses? You know, is it Ortho-K? Is it soft multifocal reusable, or is it soft multifocal daily disposable? So we're going to do our last poll here and see what you guys think is the safest. This won't cause controversy, this one.
True. Yeah, so majority of them are saying disposable soft multifocals followed by Ortho-K, and then couple of them are also in favor of reusable ones as well.
All right. So most of you were definitely correct here, is that the soft daily disposable is the safest. Now, contact lenses may not be good for these guys at all, any soft contact lenses or GP lenses. But yeah, soft daily disposable is the safest. But overnight Ortho-K, based on a recent study, is just as safe as daily wear of a soft reusable lenses. GP lenses are definitely the safest, but now we're putting the patient at a little greater risk when they're wearing them overnight. So if we look at the data, overnight Ortho-K is as safe as a soft reusable lens on a daily wear basis. Okay. And contact lenses are safer than you think. Very low risk of contact lens related inflammatory events with contact lenses. I was a part of a contact lens assessment and use group, or the CLAY research study group, and for 10 years, more than 10 years, we've been doing work in this area. And what we found is that children between 8 to 12 have a lower rate of infection than teens and adults. So you can fit contact lenses with confidence with children. And what we know, the reason why that they are pretty safe in those children, or safer than adults, is that the better compliance with the parent supervision. There was also a new study that looked at the safety of contact lens wear as far as daily disposables over time. And they found that there weren't really any significant complications in this large study of children wearing daily disposable lenses. Really no, even as far as things we look out for like GPC and things like that. So I think my point here is that you can with confidence fit these lenses in children. And if you think about it this way, which do you think is scary? And I love to see this in the chat. Do you think the image to the left is scarier, or do you think the image to the right is scarier to you? Left, the fun, this was left. Yes, the left definitely scares me for sure, right? The right, we can easily manage that. And the likelihood of that causing visual devastation is low. And my point here is I want to say is that, we can even prevent the right from happening if we manage myopia early on, because a lot of this, what happens is abuse of contact lens wear, because a patient can't see. The high myope can't really see that well without their glasses, and even with their glasses, they don't see that well. So the important part here is, you definitely, the benefits of myopia management or myopia control outweigh the risk of daily wear of contact lenses. And 2 studies, one by Gifford, one by Bullimore, did a great job at demonstrating that the lifetime risks of contact lens wear are definitely, definitely worthwhile as far as the benefits of myopia control. So now we know, okay, which option is the most effective, which option is the safest, but which option do you think is preferred by parents? So do you think ortho-K is preferred by parents? And you can put this in the chat. Do you think soft multifocals is preferred, or do you think atropine is most preferred? So we have ortho-K, we have soft multifocal, and we have atropine. Which do you think is most preferred? And let's think, and I want you to, you think about it in the United States and Asia. So both areas. Let's see. Atropine. Interesting. Okay, so I'm going to show you what we found. So a couple of years ago, I did a multi-center study where we looked at parents' perceptions of myopia and myopia control. And what they chose was actually ortho-K. And we think some of the reason was that they couldn't, they didn't worry about their children at school and their concerns about putting the drops in the eyes. And a similar study in Asia found similar results. So the parents are actually interested in ortho-K. All right. Now remember the ideal candidates for ortho-K based on the IMI guidelines, right? We're up to 4 diopters. So what do we do with children where we want to, use ortho-K? Like my patient, Sammy, his older brother was already at 8 years old. He was a 7 diopter myope, right? And if his parents really wanted me to fit him with ortho-K, what could I do? Well, some people, what they're doing is doing partial ortho-K. So they would treat the max 4 diopters with ortho-K, and then any residual refractive error was corrected with specs. And the studies that have looked at this have found great outcomes, meaning that they found 63% slower myopia progression than the control group. So this is an option for those who, we may deem by refractive error, ortho-K might be the best. You can do this. And I know some practitioners even correct refractive error even higher than this. I've even seen 10 diopters with Ortho-K, but if you want to stick with those guidelines and are concerned about decentration or staining, this is actually an option. And there are many combo options out there that have been studied: atropine, so multifocals, Ortho-K and atropine, and even soft multifocals and spectacles as well, all with great outcomes as far as efficacy. And I use this often for those children that are progressing quickly, or like my patient who's really high for his young age. Some things that doctors are doing that's thinking outside the box is using Ortho-K scleral lenses. My only concern here is some of you may know that scleral lenses can create a hypoxic environment, especially overnight. So for me personally, this is something that I wouldn't do, but I do want to mention it just to be complete. Also, GP multifocals, some doctors are doing. And of course, I think one great thing that is out there now is Ortho-K for those who have significant astigmatism. And studies have shown great results with that as well. So we talked about the management options. Let's talk about measuring success and what we consider success. So as you see there, as I said earlier, you know, the progression really depends on their background and their age. However, just in general, what we're looking for is a 50% reduction of progression, okay? As far as measurement tools, you definitely want to do objective measurements, so such as cyclo-autorefraction and using axial length. So one way to do cyclo-autorefraction is using the open field autorefractor. The benefit there is that it can measure both eyes at the same time. This is great for children who move around a lot. And then it's also less susceptible to instrument myopia. And then if you're involved in research or think about getting involved in research, it's definitely important when you're measuring the peripheral refraction. As far as axial length, there are many different tools out there today that can properly measure axial length. And so if you're really getting involved in myopia management, I definitely recommend getting one of these tools so you can properly assess changes over time. Now, the question always comes up, and I would love to see this in the chat. I think it's maybe almost the last thing I'm asking in the chat is biometry or measuring axial length a clinical necessity? So I would love to see if you can say yes or no in the chat if you think measuring axial length in the clinical setting is a necessity. All right, let's see. Yes, yes, yes. Ooh. All right, a lot of yeses. Yes, very much. Wow, this is wonderful to hear because I've given various lectures and oftentimes I hear a lot of no's. So that's wonderful to hear that you guys feel that is yes. And the why here is that it's more repeatable, it does not require cyclopegia, and it's less susceptible to changes in the anterior optics. The other reason why it's important to me is that we know that measuring refractive error is very dependent on the patient. And sometimes we don't see any change in refractive error, right, when we're doing our refraction, but there will be a change in axial length. So measuring axial length is a very important tool, and I'm glad that many of you agree with that. Even with the IMI guidelines right now, definitely in research, it is the standard, but there is definitely a push for recommending this in the clinical setting. So when should we stop? That's also a very controversial question, and we don't have a clear answer on that as of yet. Thinking about Sammy, now he's 10, when should I stop? Or should I even stop myopia control with him or who's ever working with him now? Because unfortunately, I'm not seeing patients anymore right now. But, when should I stop? And the recommendation thus far is suggested to continue at least through the age that their myopia is suspected to progress. So when he's 16 or 17 or so in 2027, perhaps I may consider stopping. However, there was a large study that also looked at this and showed that the average age of myopia stop progressing was even older than that. So 24 to 27 years old. In my mind, I mean, if it's not bothering them, then why stop it? Because even there are some studies showing some rebound effect with atropine, a little bit with the low concentration, some rebound effect in some studies with ortho-K. No real evidence of soft multifocals yet, but really, again, in my opinion, why stop it if it's not hurting them in any way? Now, getting back to the treatment efficacy slowing down, is that the case? Well, some great work done by Noel Brennan and others, and Sue Chang, have shown that the maximum mean efficacy of myopia control is lower than we originally thought. You know, over a 7-year period, don't expect more than a diopter change over that time. So we want to set the right expectations, right? We're not expecting to see 3 diopters, but more something like a diopter. So, but the benefit here is what I said in the beginning. Each diopter and reduction of myopia is associated with significant decrease in risk of disease. So I strongly encourage you to still get involved in myopia management, because every diopter does matter. Definitely get involved, as I said, because it can prevent high myopia. It is safe, as I've shown, as far as all the options. There is increased revenue, and parents are interested. So, what % of parents do you think want to pursue myopia control? 100%, 80%, 30%? Okay. 90%, 10 to 30. All right. So what we found as far as the study that we did in the States is that, and this is like several years ago, actually, and so I'm sure more now since we've done a lot of work to increase the awareness of myopia, was that 70% of parents wanted to pursue myopia. And who was doing a great job, where they heard about it, was actually the pediatricians. They didn't hear it from us eye care professionals, very few. The vast majority were hearing about it from their pediatrician. So I know the Global Myopia Awareness Coalition has been doing a lot of work in this area, and they've seen some change even as far as what parents, the definition of myopia, because what we found during that time was really eye-opening as far as what we're doing as far as patient education, in that nearly 90% of those parents were unaware of myopia control and the complications of high myopia, which was very disappointing to hear. But again, over the last year or so, the GMAC has done a good job in raising the awareness, but we have a lot more work to do. They didn't really look at their awareness of complications, but at least now 60% do understand what myopia is, at least the definition. So we're moving in the right direction. But again, we could do better with our patient education. And there are a lot of great resources out there that do a great job in patient education. One that I really like is Myopia Profile. They have great communication tools that make it easy to understand for parents. They go through what myopia is, why they should be concerned, how to prevent or slow myopia, and then what causes myopia. A lot of different sources have quizzes that you can use for the parents to understand the child's risk. So if I put in my patient when he was 5 years old, and then both of his parents were myopic, and then answer some other questions, and you can see his risk for high myopia. He already is up there now. There's also the Brendan Holden Institute calculator. Now we have that new modeling, right? As far as, how effective myopia management is over time. However, this still is a good tool for parents to just understand that if we don't initiate treatment, where their child may be, right? May not, where the child will be for sure. But as far as the treatment, it may not do as much as we see there, but it still gives them an idea in an easy, understandable form. So I still do recommend that. In the States, we could do a better job as far as utilization of myopia, 40%, and I even looked at the updated stats from Contact Lens Spectrum, 40% aren't utilizing myopia control in practice. And the biggest challenge is that the expense to the patient, and then the complex learning curve as far as, of course, ortho-K. globally is very similar. As you see here, again, uneconomical is what's holding eye care professionals back. From my experience, though, I think that, if it's properly explained on the why, the parents want to do all that they can to help their children. So I think it's all in our mind that the parents would not invest in myopia management. So what are we waiting for? There's so many great resources, continuing education out there. I think every conference you attend, there's something on myopia management. Even in this organization or series, I've seen a lot of discussion on myopia management. So the education is there and it's growing. Even the contact lens manufacturers are coming into offices and giving guidance on fitting and troubleshooting and helping the practice. So you definitely want to use that as a resource. And successes in reach. Years ago, the success rate, first fit success rate, was only 80% with Ortho-K. Now we're getting as high as 90%. So 9 times out of 10 patients, the first fit will be successful, which is really high for Ortho-K. The International Myopia Institute guidelines is another great resource. Review of myopia management, which I know you guys know, is great. Quick review or quick highlight of the latest updates. And as far as tips, I do want to add, and for you, when you get into your practices or those that are in practice, is again, you want to make sure you choose the myopia control treatment option that's best for the parents and the patient's lifestyle. For this patient, contact lenses are no-no, right? Even though maybe for his refractive error, it's best for him, but if we can't get him to wear them, then the myopia control is not going to work. And the same thing for a patient with the drops, right? If the parents are refusing to instill the drops or just being uncompliant, then that myopia control option isn't great for them. You also want to monitor and be sure you monitor properly. Each option has its own monitoring or follow-up recommendations. However, what I noticed that is consistent is definitely following up every 6 months and then the 1 month. The important thing here is that especially with contact lenses, what we see is a lot of patients, especially those new to contact lenses, drop out during the first month. So we definitely want to not just do the 1 week, but even the 1 month to just see how they're doing, even if it's a virtual, call instead of them coming in person. And then even more so after the 60 days. So I hope that what I shared as far as the GPS myopia management guide was beneficial for you, so that if a child like this one ends up in your chair, the question will not be myopia control or not. You would do what I think all of us will want to do as eye care professionals, in that we'll do all that we can to not only restore and enhance our patient's vision, but also maintain their sight. Thank you, everyone.
Wonderful. Thank you so much for that very insightful talk. I think really important for us to know what goes on, in terms of myopia management, and also the resources what you shared. So as you said, it's a learning curve. Everything needs to, you can't just hop in tomorrow and start, but you need to start somewhere, right? So that's
yes, exactly. Yes, and it does take time, but it's definitely rewarding because you're really making a difference in the child's ultimate life. Yes.
Great. Okay. And there was one question which ideally came into my thought, is when you were sharing about the esophoria. The patient has had a bit of esophoria. The mind is, does that really bother you in terms of selecting, or is that binocular vision status kind of helping you to select a mode of myopia management?
Yes, I definitely do. And I know that just based on the IMI guidelines and in general, even from, like I said, I'm not speaking on behalf of Johnson & Johnson today, but we're doing a push of making sure that checking the binocular vision status It's an important part of the testing because you want to make sure that whatever you're doing is not having an impact on their binocular vision. As far as selecting, I feel like, what I did with him, I also did vision therapy with him in conjunction with the myopia control. But with selecting, I was like, well, if I had a choice between the two, that the plus of those lenses will help relax his eyes some, with the ESO. And it did. So it helped him with when he had the contact lenses on, and then the vision therapy and things also helped him. Even without the contact lenses, he started becoming more ortho. Mm-hmm.
Great. Okay.
Mm-hmm.
One question which came on earlier in this session was regarding one case. So I know it's not complete one, but just to get some thoughts across. Similar
Mm-hmm.
condition to your patient, a moderate myope with a slight amount of astigmatism as well. What would be your recommendation and any thoughts on that?
Yeah. So, as far as the ortho K, this would be borderline as far as his refractive error, only because, above the 4, honestly, it does become a little more challenging, especially those of you as students here that are new to fitting ortho K. It's hard to get the lens to stay centered when you get to higher refractive errors. And there's also chances of causing some staining. And so that's why the IMI guidelines even recommends just going up to the 4 with the children. So that would be my only reservation with using ortho K for this child. So I would probably go with the soft lenses, or maybe perhaps the atropine, but I'd probably lean more to the soft lenses just based on the studies showing as far as the efficacy. The key thing is what I would do here is, ask the parents some key things about the child's lifestyle. Like, is he an athlete? Their motivations and goals too. Because as I said towards the end, the key to this is the parent and the child going to use that treatment option or not? But just looking at the refractive error, I would lean towards the soft multifocal. Mm-hmm.
Okay, great. And again, if would age in this case, let's say we talk about this particular case, would age be a decision-making factor of ortho K versus soft multifocal? Do you think that would be something which would?
Yeah, so age does make a difference because, as I mentioned, with the soft multifocals, they have to be mature enough to wear them at school, when they're away from the parents. So I look at, and I kind of examine that myself. I ask the parents, but then I also see how the child acts in the office too, and their maturity level. So yeah, age makes a difference. Normally for a 5-year-old, I wouldn't go with the soft multifocal, but if they're mature enough, then I would go with it. Mm-hmm.
You would. Okay. So age, again, keeping all that thoughts in mind, is really important.
Yes, it's very important.
Great.
Right. Everyone is an individual. So yeah, I know my students just always ask me, what's your go-to lens? What's your go-to? And it's no such thing. I really base my decision on the individual. I put everything together as far as the research, as far as the patient's refractive error, and then what the lifestyle too, and make that decision from there.
Okay, great. Another question, again, is more of case oriented, but there is a 26-year-old female and we are looking at low levels of myopia. It says that few years ago, patient did not have any correction, but suddenly 3 years before has started wearing glasses. So at this age, 26-year-old developing myopia, should we consider myopia management for this patient, and should we consider ortho K in particular for this particular patient?
Mm-hmm. Yes, this is an excellent question. I need to add it to my presentation. But so we don't have any clear evidence of the benefit as of yet. I know people are working on studies as far as the efficacy of myopia management for someone who is older. However, if I start seeing a young adult progressing, their myopia is changing rapidly, I would first double check that prescription thoroughly. And then I would, if it's true, then I would consider initiating it. But also explaining to that young adult, and if their parent is also involved, the expectations. I don't know how much is going to slow the change in prescription, in their refraction, but let's give it a try. And we'll just monitor from there. And then I also would, look at their lifestyle. Like, are they doing a lot of near work, and look at those modifications as well. Yeah.
Okay, great. And one question which just came up here is asking about, again, this is more of a personal favorite question, but so it says that, do you really look at atropine and combined treatments as your favorite option? Or do you keep them for higher myopes? Is there some thought of combined treatments in higher myopes versus the lower myopes?
Yeah, so I look at that. I think of it as, just like you think of drops, right, for glaucoma, right? The more drops a patient's using, the less compliant they're going to be. So the same thing, if they're doing contact and doing atropine and doing all of this, the less compliant. So I really reserve those combo treatments for those who I notice, like, just doing the one is not helping as much as I would expect. Or if I feel like they are really high for their age, like my patient, I still haven't done combo, but he was someone I was considering doing, because I was like, wait a minute, he's so high, But so far, as I showed, we're keeping his myopia pretty stable without doing both. But the key for me there is more so, if that one treatment option isn't working, I might start combining, and it's not working, not because they're not compliant, it's not working because it's just not enough.
Okay. And another question is the importance of fundus examination. So how frequently would you recommend, because we saw that high myopia is associated with changes in the fundus. So any thoughts revolving on how frequently and what signs are we looking at which should alarm us? Anything?
Yeah, the annual eye exams for these patients. However, they should look out for the signs of the flashes and the floaters and come in immediately for that. Now, if they start, it just depends on what I'm seeing in the retina, but just, your regular high myope with no symptoms, then just annually checking their fundus exam.
Okay. And how about the axial length then? Do you repeat them annually as well for?
Axial length? No, I do that every 6 months. Every 6 months, the annual for the axial length.
Axial length you prefer? Okay. Okay, great.
And you're not really expecting a big change in 6 months, but it's just really to see that you're, going in the right direction.
Okay, great. And I'm just gonna take a couple of more questions which have just popped up. This is again something related to choosing ortho-K as modality of treatment, where we have patients with high myope as well as high astigmatism. So would there be an change in the efficacy or effectivity of the treatment in your experience?
Yes. So that's what I was saying. Like, now we have options that really correct for the high astigmatism to a limit. I would say like maybe up to 250 is what I've seen for myself clinically that actually does work. And then study-wise, there was a couple of studies looking at toric ortho-K and it having efficacy similar to the more standard ortho-K. So no, it actually does work. Now, if we combine the high myope part, I haven't really seen studies that are like high, like greater than 6 diopters and high astigmatism to support that. I haven't chanced it myself, just to be honest, like having a high myope and high astigmatism with ortho-K. Like, I kind of stick with the 6 as far as the spear. I don't go higher than the 6 for me personally. Yeah.
Awesome. Great. And one question before we end, again, this is something which is asking your personal opinion in terms of treating a 9-year-old kid, active 9-year-old kid who is more into sports, has -5 diopter of myopia. but has been stable for certain years.
Oh, that's a good one.
Would you bring this patient for myopia management, or you would just observe in terms of looking at the refractive changes?
You know what? I would explain to the parents my position as far as him having that high myopia, for his age, and that he's been stable, and say, you have an option to, us continue to monitor him, closely, or do the treatment, which for them, I don't think is any burden. And I would talk about the benefits of wearing contact lenses in general, not even looking at for the myopia benefits, myopia control benefits. I would just talk about the benefits of contact lenses and look at it that way. So the parent would see it as, okay, either way, it's a win-win for us to put this 9-year-old in contact lenses, and if they still are kind of, hesitant, then I would go over that outdoor time thing, as far as they can do the outdoor time and the near work, just so that he doesn't start progressing. The challenge here in this particular example is also if I feel like this type of patient is going to come back. So I think some of you that are practicing, you get a sense from that patient and the parent, are they patients that I'm not going to see for 6 years, versus the parent and child that I know they're going to come back to me every year. The one that's going to come back every year, I'm more likely to be not as aggressive and say we need to just put them in something just in case, versus the parent that I only see that parent every 6 years. Then yeah, I probably just push it and do it. Yeah, because I worry. What if the next year he changes and they don't come in?
Yeah.
Mm-hmm.
But at least putting these thoughts in parents' mind that there is a myopia management which is available, and whether it's been stable or not, we need to monitor it closely and get them for follow-up. At least that's, I think, probably the least we can do.
Right, that
in outdoor, right?
Follow in the outdoor time, and go from there. And again, like I said, what is the harm? It's such a low risk of complications with contact lenses in the first, like doing something. Like I think whatever option, even the spectacles. So
Yes, that's
yeah.
right.
Mm-hmm. Mm-hmm.
Okay, so I think with that we have taken all questions. Thank you so much, ma'am, for doing the session for us, and being that GPS guide, as you said in the title, for us to navigate through and manage our patients with myopia.
Thank you. Thank you for the invitation. It has been a pleasure. Thanks everyone for joining.
Most welcome. We do have a session next weekend. It is on scleral lenses, specifically on fenestrated scleral lenses. And we are going to have Dr. Donald Lezical. I think he's one of the pioneers in scleral lenses, and he's going to come and talk to us about his journey of how he started fitting gas lenses, gas permeable glass material lenses, and put fenestration to them. Take care until then. Be safe. Thank you.
Bye.
Bye-bye. Thank you, ma'am. Bye.